or your urine may look cloudy. All these things are potential symptoms of urinary tract infection, cystitis. Now, it's important to treat a cystitis, even if by the way, some cystitis is completely asymptomatic. But if you're aware of a cystitis, it's important to treat it, because if you don't and you allow the bacteria to propagate, they can make their way retrograde up into the kidneys, and then you develop a pyelonephritis, which is a much more serious infection. Whereas cystitis may not be associated with fever, pyelonephritis is almost always associated with fever, and tends to be a high-grade fever, like varying from about 103 to 105 degrees Fahrenheit. Whereas cystitis may not be associated with an elevation in the white count, pyelonephritis is almost always associated with leukocytosis. In fact, many times, if the white blood count's above 20,000, you'll put the patient in the hospital, because then they're at risk for sepsis. As we'll see as we talk about the kidneys are very, very vascular organs. And so if you have bacteria propagating within the parenchyma, the tissue of the kidney, it's not difficult for those bacteria to seed the blood vessels within, and that can lead to a blood-borne infection, what we call sepsis. Sepsis is life-threatening. Now, sometimes with the pyelonephritis, you'll have some of these same symptoms, but in addition, you'll have extreme flank pain. So if you percuss the flank area, in other words, you just take your fist and do like this. As you percuss the flank region, the patient has, complaints of extreme pain. Whereas you don't have any other degree of pain associated with the cystitis. So many of the organisms that cause cystitis are the same organisms that cause pyelonephritis. But in addition, sometimes pyelonephritis, instead of spreading from the bladder, it comes from hematogenous spread. What do I mean by that? Well, let's suppose, for instance, that a patient has an osteomyelitis, an infection of bone, and those bacteria from the infection of the bone, from the osteo, seed the bloodstream. Well, because the kidneys are so vascular, sometimes those bacteria, when they seed the bloodstream, they settle out within the kidney and cause kind of a secondary pyelonephritis. In that case, the pyelonephritis is not going to be due to one of those typical gut flora, gut bacteria. Instead, it might be due to something like staph, which was causing an infection of the bone. Urethritis, infection of the urethra, is not typically caused by a coliform bacteria. Instead, urethritis is usually sexually transmitted. Urethritis is more likely to be caused by an organism like chlamydia or gonorrhea. So usually a urethritis is going to be sexually transmitted, and that can cause some burning with urination, or it can cause a urethral discharge, what some people call a drip. Now, when we're evaluating somebody for a disorder, including an infection of the urinary tract, one of the common types of tests that are performed is a urinalysis. Urinalysis. There are two components to the urinalysis. urine chemistries, and a microscopic component. Okay. Now, one of the most important things about obtaining a urinalysis is that it's done properly. You'd be surprised how many people who correctly assume they have a urinary tract infection, but they collect their own urine at home. They'll collect it like in a jar, and they'll bring their urine to the clinic. Can you use it? Can you use that urine? That wasn't collected properly. Okay, it's going to be contaminated. Okay, so what you want to do is make sure that if there's any bacteria that are present within the urine, that those bacteria actually came from the bladder and not from outside the bladder. And so the way we typically collect a urine specimen for urinalysis is by using a midstream clean catch technique. Have you all heard of this midstream clean catch urine collection? The midstream part means that you have the patient begin to urinate into the toilet bowl, and midstream they stop. And what that does is, if there were any bacteria that were present along the edge of the urethra, near its opening or meatus, those bacteria are flushed out when you begin to urinate. Okay? And then you stop midstream. What does the clean catch part mean? Well, before you start to urinate, if that's the urethra, you're going to take some type of antiseptic solution, like you could take a betadine swab. And what you do is use a little technique where you clean the area right around the urethra in an ever-widening circle like this, so that you make that region around the urethra more antiseptic. You're gonna remove bacteria. And then, so you clean the area properly. Now, you would never go from outside to in, because if you do that, you're dragging bacteria toward the urethra. So it's an ever-widening circle, and then you have them perform the midstream part. Okay? So they stop midstream, and then they pee into a sterile container. It's important that the container is sterile. So typically, a urine collection specimen cup will be sealed, and you have to break the seal right before you collect the specimen. Now, believe it or not, a lot of patients, even with proper instruction, they can't do this part correct. Okay? So many times you have to send one of your medical assistants into the bathroom with the patient to help them collect, to make sure, to ascertain that it's done correctly. Okay? So you're going to have a little cup here with the urine. Now, you either need to test the urine immediately, or if not, put it in a refrigerator. Okay. If you don't have the capacity to do a urinalysis at your office, then you have to either put it right into the refrigerator or send it right to the lab. And when the lab receives it, they'll put it in the fridge or they'll perform the test immediately. What the refrigerator does is it lowers the temperature of the urine so that inhibits propagation of bacteria. Because otherwise, if you leave the urine at room temperature, even a single bacteria getting in when you open a cup, at room temperature, it doesn't take those bacteria long to propagate. Okay? And so you'll have a urine specimen full of contaminant. Okay? Now, you're going to pour some of that urine into a test tube. And what you can do is, there's different ways of doing the urine chemistries, but the most common way is by just dipping a dipstick in there. If we have any of these things to carry through those things. Have you all seen dipsticks before? It's just in a little bottle. Okay. The dipstick thing like this that you can dip into the urine, and it's got lots of little color indicators. The And these color indicators test for different substances in the urine. Or they may test for the specific gravity of the urine or for the pH. Okay? Specific gravity is an index of how concentrated the urine is. So if someone is volume depleted, the specific gravity would be high. If someone is water overloaded, it would be low. One of the color indicators will check for the pH of the urine. Okay? Another one of the color indicators will be to check for glucose. Another color indicator will check for protein. Now, normally, should you have either glucose or protein in your urine? No, comes out. Typically, the pH of the urine is slightly acidic. With certain types of bacterial infections, for instance, like Pseudomonas, the pH becomes more markedly alkaline. The pH climbs. With the dipstick, you can check for ketones. So if someone was in ketosis, either from starvation or from diabetes, the urine dipstick will test positive for that. There's a color indicator for blood. Now, there are lots of causes for blood, sometimes even cystitis. In fact, that would be called a hemorrhagic cystitis, where the bacterial infection erodes the surface mucosa, causes some bleeding. There's one for something called leukocyte esterase. This is just a little enzyme produced by white blood cells. So that if someone has an infection within the urinary tract, then those white blood cells release this enzyme. It's detected by the dipstick. It's going to correlate with the microscopic finding of white blood cells. Bilirubin. Yeah, you expected that. Urobilinogen. Nitrites. Certain bacteria produce nitrites. So if you see 3+ or 4+ nitrites, you have to expect an ECI. So these are all substances that will appear in the urine in the presence of certain urinary disorders. Okay. For instance, if someone has, let me ask you this, if someone's got sickle cell anemia, where they have a hemolytic anemia, where red blood cells are being broken down at an accelerated rate, would you expect to see bilirubinuria?
No.
No, because it's unconjugated. But if they had the situation we had in our test, where someone had an obstructed common bile duct, whether it's from a stone or whether it's from a cancer in the head of the pancreas, then we would expect to see bilirubinuria. Now, if someone had sickle cell anemia, even though there wouldn't be bilirubin, would have an increased amount of urobilinogen. Remember? If someone had diabetes and it was severe enough, we'd see glucoseuria. Okay? Or if they had it chronically and it caused damage to their kidneys, a diabetic nephropathy, we might see proteinuria. You see what I'm doing? I'm adding that URIA at the end. That means that it's present within the urine. Okay. So the first part we do is the urine chemistries, then we do a microscopic. And here's the way we do a microscopic. Is we take that test tube full of urine and we spin it down in a centrifuge. So a little cap of sediment is going to form at the bottom, okay? Meaning that any particulate matter or cells that were present within the urine get spun down and become part of the sediment. After we do that, after we centrifuge, we pour off the supernatant, the stuff that's on top of the sediment. Take the sediment and agitate it a little bit. and then take it out onto a microscope slide and put a cover glass on top so that we can examine it under the microscope. And we examine it under the microscope, we're going to examine it at two different levels of magnification. We're going to use the low power. I think that's the yellow band. That's called a low power field. And then we're going to use the high power, which is, I think, what it was, the blue band. And that's called a high power field. Okay? And what are we looking for when we do a microscopic? Well, we're looking for red blood cells, like little refractile circles with nothing in them. Sometimes they kind of have a reddish tint in a freshly poured urine. Okay, and the person who examines, the tech who examines the urine, will quantitate the number of red blood cells. For instance, it's normal to have somewhere between 0 and 2 red blood cells for high power field, and that's the way it will be reported. That's within the range of normal. But if you start seeing 10 or 20 red blood cells, that would be abnormal. Sometimes there's so many red blood cells that you can't count them. Okay, and then the lab tech will report something like this, TNTC, which means too numerous to count for high power field. That might be the case, for instance, if you had a kidney stone that was scraping the ureter and causing some bleeding into the urine. Then you'd have too numerous to count red blood cells. Now, if instead, or in addition, you have white blood cells are slightly larger, but you'll be able to see nuclear material inside of them. And so they'll have a slightly different appearance. Okay? And just like you count the number of red blood cells, you count the number of white blood cells. Again, if there's like 0 to 2 white blood cells per high power field, no biggie.